Hi, my name is Lauren, and today we're going to be talking about opioids for our group project. In my group is Christina, Danielle, Jamie, Molly, Adelaide, and Hedger. We want to start out first with explaining the mechanism of action of opioids. Opioid agonists act to relieve pain in the central nervous system by mimicking opioids that our body already produces, and this occurs primarily at the mu receptors.
So the indication for opioids is pain, and it can be absorbed subcutaneously, intramuscularly. It can be absorbed through the mucosal membrane. It can be absorbed transdermally, and it can also be absorbed in the gastrointestinal tract. When it's absorbed in the gastrointestinal tract, the first pass effect must be considered.
So opioids are protein bound. Skeletal muscle is the largest reservoir. Opioids have a hard time crossing the blood-brain barrier, which is why they are contraindicated for neonates, because they do not have one.
Okay. So the metabolism of opioids is hepatic, and if the patient is in liver failure, they will require a smaller dose. And excretion is through the renal, which is through the kidneys.
Okay, so patient teaching for opioids. First, you're going to teach the patient how to use the PCA pump. Next, let them know that it's a potential for addiction. And common side effects will be respiratory depression, constipation, orthostatic hypotension, which you want to let the patient know to change positions gradually, urinary retention, cough suppression, biliary colic, emesis, nausea, vomiting, euphoria, sedation, pupillary constriction, birth defects, which is why it's contraindicated for pregnant women, and neurotoxicity. Also, patient teaching and family teaching would be to hydrate yourself and make sure that you eat a lot of fiber because it makes you constipated. And that's it.
Opioids are not routinely monitored in the blood, but if a physician wanted to see how much opioid you have in your system, he could do a tox screen, pre and post assessment before you give somebody opioids to monitor for respiratory rate and depth, check their pulse, blood pressure, and always ask the patient their pain score before administering an opioid.
Okay, so the dosage of opioids depends on which route it's given. If it's given orally, you give it between 10 and 30 milligrams Q4 hours. If it's IM or sub-Q, you give it 5 to 10 milligrams Q4 hours. If it's IV, between 4 and 10 milligrams, and there's no limit on how often it can be given. Also, if you give it IV, you want to give it slowly, between 4 to 5 minutes per dose. If it's through an epidural, it's 5 milligrams Q24 hours. Things that would affect the dosage would be liver failure, because you're affecting the metabolism. The pain, the amount of pain, if they're in higher pain, they might get higher dosage. And the third one is tolerance to opioids. If they've been taking opioids for a long time, they might require a higher dose. Contraindications include pregnancy and neonates, which is not written here. And then also the treatment for overdose is naloxone. Yeah, that's right.
Oh.
Opioids.
Opioids, got it. Here's your blooper video.
Okay.
First, we just want to start off by saying our agonists that relieve pain by acting on the central nervous system. Oh, shit.
You got it.
I just can't even right now, guys.
Okay, you want me to do the mechanism?
Yeah, no, I got it.
You got it.
Okay.
You want me to keep going? Because I kept going.
Sure.
Okay.
Well, then it's gonna be like.
Shit.
And it's absorbed through subcutaneous, intramuscular, mucosal, transdermal, and gastrointestinal. So once it's absorbed through the gastrointestinal